ethical decision can be different categories according to the complexity. So straightforward, low complexity, moderate, and high complexity. The high complexity are the ones that require extensive number of diagnoses or management options, or have several management options, extensive data reviewed, potentially including multiple tests, specialist input, high risk of complication, morbidity and mortality. So these are the most complex, for which usually you ask advices. So the key aspects of difficult medical decision: uncertainty. So the lack of clear evidence about what is the best course of action. High stakes, there's high risk for the life or very severe complications. Conflicting values, the different opinion between patients and doctors, so they cannot come to some consensus. Complexity, as we were saying, multiple factors, risk-benefit considerations, and ethical consideration, balancing the right of patient autonomy and the duty to provide the best possible care. Now, just a list of issues regarding the end-of-life decision, which are the most difficult ones. So, first of all, there are some basic principles like key ethical principles, for example, patient autonomy, so to respect always the will of the patient, including desire of the patient, very sick, and one is still capable of thinking and expressing his will, decides, I want to die if, so it should be respected. Beneficence, non-maleficence, doctors have always to be inspired by this issue, by these principles, and justice, to give equitable distribution of resources and care to all the patients. Everybody has the right to be treated. Now, there are different doctrines behind these principles. The ontology is that, what is right, what is wrong, so we deciding based on that strict differentiation. Otherwise, there is the utilitarianism, which is a doctrine that privileges the choices that benefits the most. So, for example, if the patient too sick, requires so many resources, and to the detriment of the many others that could be treated, that don't have any more resources, they go for the second option. Virtue ethics, like compassion, integrity, wisdom, so making decisions based on this doctrine, or cultural and religious consideration. Now, some key bioethical issues that we will see also in the following slides. The issue of informed consent capacity. The patient has to be able to give consent. He has to be mentally capable. Involving the family in the decision. Decision about withholding or withdrawing treatment in patients that are too sick to continue, and so you don't want to waste any more resources which will be useless. Palliative care and symptom management. Patients that are reaching the end of their life only need to be made comfortable. Euthanasia and physician-assisted suicide. Here there is a big issue of respect for patient autonomy and relief of suffering. In Italy, this has been a big issue, and there are occasional cases that are in which there is the permission to go ahead with physician-assisted suicide. So it's the patient that pushes the syringe to end his life because it can no longer tolerate the pain and the sufferings. Now, is age a factor? neither old or young. However, there are some considerations. For all patients, age is a factor, is not a determinant. It depends if the patient is still in good shape, if he's in this advanced cognitive decline or well preserved intellectually, advanced care planning. Young patients, there are some rare cases of extreme complexity and with very difficult chances for recovery. There are not enough resources, and for example, patients with genetic anomaly that we know already that they are not going to survive too long, and that therefore we don't want to use too many resources for those. Okay, I call this extreme mercy end of life decisions. Again, assisted suicide, and I already explained what it is. Euthanasia, there is active and passive. Euthanasia is the doctor actually causes following the desire or the will of the patient before when it was conscious, and he cannot, maybe he has muscular disease, he cannot even procure his own death. So it is active, but actively done by the doctor, or passive, which is a kind of similar to withholding or withdrawing treatment. Examples: palliative care to avoid medical fertility, and this is a more or less acceptable on a religious ground. You can stop me if you want to have any question, just for clarification. Julia, yes, question? No.
Maybe, for example, what about this situation? Like, is the doctor responsible for the will of the patient or not? Like,
No. It's, first of all, you don't reach this stage just because the patient said, "I want to die." Okay, you're right. It's better. There has to be ethical committee, multiple. We will discuss that we need difficult decisions in the end. So it's not like you say, "I do it," and also it's not even allowed by law. There has to be some legal level that permission to go ahead, because the patient clearly cannot tolerate anymore. It's at the end of the life. It's better to finish and avoid the sufferance. I don't know what is the situation here. Is there such a practice, or no assisted suicide?
It's absolutely forbidden.
Forbidden, right? Yeah. Okay. Abortion, here it's a big issue. First of all, there are issues like the moral status of the fetus. Does it have full rights from conception? And also we should decide, respect the autonomy of the pregnant person, woman of course, who has the right to decide. So even here, we can decide anything about abortion, but there's one person that has to carry on, and is going to take the burden and all the consequences of such birth. So you have to respect what is the desire of this person. Okay, beneficence, patient beneficence and non-beneficence, justice, provide fair access to abortion service. If some countries, like here, also is not forbidden abortion.
In some rare occasions, it's possible.
It is possible,
Like endanger the life of the pregnant woman.
Okay.
But I don't know about rape.
Okay, now there are the special cases below. For example, I heard that many Ukrainian ladies came to Poland after being raped, the Russian invasion, and the abortion was denied for religious. In a way, if they wanted that procedure and had no access because of the particular law of this country, so they don't have free access to abortion, right? Because now I don't know what you think. As a result, a pregnancy as a result of a rape, of incest, or the presence of severe fetal abnormalities, unless there is threat for the mother's life and health. I don't know what you think, whether this should be. I know, you say you let him get birth, and then maybe can be assigned to some institution that can take care. I know what is usually the answer, but yeah. All right, so this is a very, very debatable. So let's go ahead. Again, genetic abnormality. For example, prenatal genetic testing showing very bad genetic anomaly, so therapeutic abortion. Yeah, let me tell you, I've seen some very great disasters for patients that maybe you can say the first word at 30 years of age, Does it make sense? I don't know. It is a life, yes. But, and the church, the religion says everybody has the right to, and what you have to do, you have to provide this individual with a decent life, comfort, having not to suffer during the life. But, so again, children that are born with severe genetic disorder, and they start treatment, or even with severe cardiac anomalies that don't go well after the surgery. How many resources do you have to employ for these patients to the detriment of others? Now, even adults with genetic predisposition, okay, there are adults with the genetic predisposition to generate children with relevant inherited genetic anomaly. So couples that we find out that they have this transmission of genetic traits that lead to severe problems. So there should be some reasonable approach to avoid, maybe adopt, rather than generate more children. And I don't know if you are aware, I'm sure you are aware of this case of the Chinese scientist that in 2018 created the first human genetically edited babies, and which was condemned by the entire world as a very unethical thing. That would be the beginning of eugenetic approach to humanity. That would be humankind. That would be terrible. Overtreatment, again, patients are doing very badly after an operation, and you keep assisting, employing all the resources for these particular cases. So it's the relation of beneficence and non-beneficence, a problem with resource allocation. The patient maybe doesn't even have the right, the possibility to express his own will. And this point is very important. Defensive medicine. And obstinacy is not really, doesn't really mean caring for the patient. So for example, let's say in my case as in my discipline, there is a patient that everybody expected to go well, but somehow the operation did not all go the proper way, and they don't want to lose the patient, they keep assisting even beyond any reasonable hope. And is this really caring about the patient, or is just defending yourself from legal consequences, or bad reputation, and so on. It raises overtreatment economical considerations and causes emotional harm to patients and families. So that as a corollary of this point, addressing overtreatment. So we need to expand the culture of value-based care, distributing the resources appropriately, improving patient education and engagement, and also promoting systemic issues like transparency and accountability. So we need to do the right things, not overdo when it doesn't make any more sense. But of course, you have to do the best you can to save the life and to make the patient feel as best as possible. Then there are limitations, unfortunately. Other example of end-of-life decision: do not resuscitate orders. You massage a patient that had cardiac arrest for 45 minutes. There's no more point to continue. Stop. Or you just patient that is so severe that maybe they already had a cardiac arrest before, but at some point say it's been not going anywhere. Next time you don't resuscitate because it will be useless. You just prolong the sufferance. Like suspending mechanical ventilation in severely ill patients. And the next point is suspending therapy in terminal cancer patients. Again, a patient that no more hopes, you just stop treating beyond any reasonable justifications. Or not offering treatment, for example, surgical, with high mortality risk. And here the dilemma is it problem of complexity or lack of expertise, and maybe you send the patient somewhere else? And other examples as well. Now, again, this is the compass, between doing the knowing what to do and also having the ethical mind. But here in particular, the painful debate is a different thing actually, not exactly the same comparison. And usually, and that's what I really feel in front of some patient, that you have to balance the security of life. So when you try to save the life of the patient, it is a dilemma between religion that say you have to do your best to save the life at all costs, versus compassion, virtue ethics doctrine. I don't know if I explained well this concept, but it is a balance between religion and virtue ethics when you have a patient with end-of-life situation. I think concluding here, the toughest, the most difficult medical decision is for a doctor is when not about choosing between right and wrong, but between two rights. When saving one life may mean losing another. Okay, this is a statement attributed to Hippocrates: cure sometimes, treat often, comfort always. Now, this is often quoted in the context of end-of-life and palliative care decision. Now, the title was to where to get help. Now, it's very simple actually. First of all, you need to, because this was when you have this moral decision making, ethically you have to say, can I handle this case? This is beyond my experience, my knowledge. I need help. So you understand that when you have to, with the balance of conscience and intellect, when you can handle a case, or you need to go for asking a consultation, advice, collaboration, more experience, or more colleagues. In fact, there are these different types of consultations. I would say professional, like an expert, calling an expert in your discipline, a surgeon more experienced to come and do, or help you to do, or teach you how to do, or for example, asking a multidisciplinary meeting about a very complex patient. And so there is not only a problem with the heart, there is a problem with the liver, with the kidneys, and so you gather all the specialists in order to discuss the different aspects of the treatment of this patient and make a common strategy. Or there are cases like end-of-life decisions where an ethical committee may be indicated, or an administrative consultation for an issue of affordability. Is a patient that have already requested so many resources employed. Can the hospital cope with this expense? And all this together may help you to reach the most reasonable solution for the patient, respecting all the rights that he or she has. In the difficult cases, the final decision has to be taken by one person. It can be the doctor or a family member. When there is no way out, this is I didn't say this, but Dr. Buchanan and colleague published this, in which they say at some point if you cannot find a solution, one has to take a decision, either way. And now, if the family decides we prefer our beloved one not to continue the treatment because there is no hope, we're suffering, etc. You respect that because there isn't actually any valid alternative to propose. Now, this is the last one. Excuse me. It has to be clear that seeking help for difficult decision is not weakness, it is strength. Because you are responsible, you want to do the best for the patient. So don't be afraid to ask any suggestion, help, assistance, guidance, etc. to somebody or to more colleagues around you in order to reach the best decision for the patient. I think this is the last one, yes. So this was the second one about difficult decision that actually continues what we said yesterday about the balance between conscience and intellect, and this issue is expanded more in the second chapter we just saw. We need to take difficult decisions. So we need to balance all these aspects. So if you want to ask me any questions, I'm here to try to respond.
So I have one question. I heard something about the case that a little baby, not so little, like 4 years old or something like that, was heavily ill, and this child wanted to die, and the parents go with his will, took from hospital and let die in home, not no, they didn't continue the treatment, and in this case, which?
Okay, first of all, was this child like a terminal one?
Yeah.
This is a extreme case in which why not? He was old enough, even though very young, to have feelings and the capacity of saying what is desire. And if it really was an hopeless situation, why not? Because it is a matter of sufferance, and in that status, you want to finish as soon as possible. I've seen, for example, we're talking about assisted suicide and so on. Patient that with the SLA, not the scleroderma, this is muscular dystrophy. He could not, it was bedridden, ventilator, skeletric, not even able to almost to do anything, so that could push the syringe, of course. And deciding want to die because they're suffering. The life like this, it doesn't make any sense. And I saw some video of this patient just before doing the final act, and happy, smiling, say, okay, I'm going to finish this suffering because I prefer to die rather than continue like that. Now, there's what you asked me gives me another hint for another answer regarding patients. For example, parents come to you and they don't want to have treatment to their son, to their child. That has actually great chances of success. For example, a surgical operation that statistically solves the problem, goes very well. But parents don't want to have a patient, for example, that has a cardiac story, and cardiac anomaly, cardiac operation. Usually, for example, if they are trisomy 21, and so in that case, the doctor or the hospital can take action. Say, you remove the patient from the care of his parents, and you can assign to an institution, because that is not right. Now, when it is possible to do something to save a life, why do you want? You decide for your child, I want him to die. Why you cannot, or not to offer an option that can change his life? Why not? And in that case, you can remove the responsibility from the parents. But the case you said before, I would consider it as a possibility. That no more chance the child is intelligent enough to say what he wants. He doesn't want to suffer. Let's respect his desire. I don't know what all of you think about it, but it's you have to respect also when it is reasonable, when there is no more option, and you have to do your best to alleviate all the sufferings, but it's not always possible. And the patients express their desire to end everything. They prefer to die rather than continue with this.
But I think also about if this child or any mother has so much consciousness or intelligence to understand it. Like, child also doesn't want to eat vegetables or take a pill to help. And what in this situation like?
Of course, cannot generalize, and of course, it's not a decision you say. The child wants to go. Okay. Discussion, consultation, maybe psychologist, it's not a decision but as an end result, he is grown enough to express desire, which is reasonable. It's not that unreasonable. This child has very little chances to survive. If he survives, he suffers, and he doesn't want to have that. He has actually intelligence, if you think, because he is able to elaborate his condition in a way that he decides that he doesn't want to continue. He prefers to finish treatment, useless treatment. It's difficult, of course, and again, I have only considered in my life, marginally this kind of issue, because it's not so frequent to have this situation, but they can happen. That's when you speak about this topic, you end up considering all the possibilities. And of course, I would say that when you are, I worked for the Vatican many years. Not only the 14 years I directed, but before, I had a parenthesis in the States in between, but then before I was in the same hospital as one of the associates. And so I know how the church, Catholic Church, thinks. And they say, life should save the life, of course. And then, when there are situations like very complex patients with severe anomalies, trisomy 11, they say, comfort care. Don't do surgery because it is kind of useless, because these patients are not going to survive long. But just make sure that this individual doesn't suffer. And why I'm saying this, we are here at the retreat, spiritual retreat, Christian, Catholic, and of course I imagine all of you here are inspired by this, and I don't want to deny that. I am a little more realistic and utilitarianistic, but not for the good of the society, just for the good of the patient, and also the many others that require treatment. At some point, and believe me, I've been, when talking about obstinacy, I've been obstinate to pursue the survival of patients throughout my life. I know sometimes it was just beyond reasonable expectations, because you try to do your best, make an effort, you don't want to lose patients, but then self-criticism, sometimes it was exaggerated, and even church might say, okay, comfort care, because beyond that doesn't make much sense. So you need to be ethical and respect the patient, of course, and do the best for the patient. And then limitations, there are a lot of other considerations. All right.
I think that there is always a moral dilemma or question who has to assess if patients, or for example child, is able to make a conscious decision about his or her life. And I think it is very difficult, for example, when patients is suffering, because normally we assume that people wants to live, wants to life long and health.
Sure.
But when someone is suffering, it's very difficult to assess is it real will to die, or is it just contemporary decision or contemporary state?
Is very, very correct. So I don't want to rephrase what I said earlier, but I was emphasizing the fact that this decision has to be taken after full analysis of the situation, and reliability of the patients in requesting such a thing, and whether you should, accept what he says. You know, I don't know if you ever had, like, I remember sometimes, occasionally I have very strong headaches, and you feel so, frustrated and suffering that you just almost decide to die because you don't want to continue that pain. Of course not, but to say that I understand, like a child, I might say, it's a perfect example of what you say. Can we rely on what he says? But if after assessment, this decision, this request by the patient, young patient, and potentially not in full possession of his own faculties, says something that is reasonable, and he really suffers. You can see if a patient suffers or is kind of protesting or something like that. So anyway, all this is correct what you said, and but I reply to that. It is a decision that had to be, balanced, all the possibilities, and of course you don't just go that, okay, go. It cannot be like that.
And I'm wondering one thing, what is more important for doctor, to save life or avoid suffering? But because I think suffering is a part of life and everyone is suffering, and I know that it's some kind of suffering that it's very hard to
You
live
are
with,
absolutely
but
right, but the point is not that life versus sufferings. The life is a no longer possible life, long life. It has to be a certainty that the life cannot be continued for long. We can only continue as the sufferance, because the clinical problem that the patient has is incurable. That is the situation, not that I don't want to suffer, I want to die. You can say that just for, but it's not true. As you say, everybody wants to live. But I like these comments you have been doing. They're all partially correct, but you have to see the context and what in which you may find yourself in front of a situation in which there is no hope, objectively, no hope for long survival, and just prolonging may not be the case, may not be appropriate for the patient, for the community, etc., etc. So it's. See, I say this, I would have made this kind of comments. Is that even more extremist before, because they have to save the patient at all costs and continue until there is no more hope. And I know I have a colleague who is older than me, and he follows patients, and I still do surgeries, but it's basically he was asking me to give to do something for a patient that is clearly hopeless. But after 80 years of age, long experience, how can you still believe that there is a reasonable alternative for this patient? It is not treatment. You're going to do another treatment. You're going to use resources, and because don't get surgery basically. And the patient is other sufferings, other struggling for everybody, for the staff, for the doctors, for the hospital that has to invest the resources that are going to be wasted. So there has to be some realism. Does it really make sense? If yes, everything you need to do you can, it has to be done for saving life, of course. I don't know if I give you the, I'm not saying it doesn't make sense to continue, just to be sure that there's really no more possibilities of saving the patient. Because you know how certain terminal cancer patients, many cancer patients decide not to have proper pharmacological treatment. They go with alternative solutions that are constantly failing. But terminal cancer patients, you can keep them alive, yes, but then for how long and what cost, and what cost us in terms of sufferance. But it's good to be, how do you say, advocates for life at all costs, because that is what has to come from your heart. But with time and experience, you realize that there are situations that you need to be reasonable also, especially because, as we will see later also, the demands in medicine are increasing and the resources are decreasing. So the costs are rising. You need to balance. There's less investment in the health, privatization, and because those who continue this profession usually choose the way to earn more money, because otherwise they stay in the hospital, don't earn enough, or at the university, for example. So what I'm trying to say is that yes, being a little more the word not wise, but realistic. I would say realistic. Putting in the balance the options, the possibilities, the pros and cons, and unless you're clearly doing something that is against ethics, like you can say the patient you decide not to do because it's too costly, I agree with you. That you should not think like that. To do everything you can for the patient, which is reasonable, not unreasonable.
But there is a question: who has to decide which decision is reasonable or which one is not reasonable?
Okay, if I didn't spend too much on this issue, but this one wants to summarize the concept. You're not alone in these decisions. You need to escalate from professional advices to ethical committee, and also the situation of your hospital. See, to do this, you need 1 million euros or heart lung transplant, for example. Yes. Yeah, if you are possibility to do, of course you have to do, but can you really afford it? The hospital maybe doesn't even have 1 million to spend on that patient. If you send the patient somewhere else, of course. If there is a possibility, send the patient somewhere else if the patient is salvageable. But if it is there, you need to take care, and you cannot afford that, what do you do? Reality is like this. It's not that we are becoming richer and richer. But I can see few people become richer, much richer, and the others become poorer. Is it, Italy is like this, for example, right now. I don't know what this is here, but it's no one is really doing very well. And the big ones espouse other projects. The space, politics, what is most convenient for them. Can we go to the next?
Maybe.
All right. If you discuss more about this? The next one is about the patient's knowledge, if I for medical cooperation. I think when you talk about medical cooperation, we talk also about this. Number 3, right?
Yeah.
Until what time should we stay here?
At 11.
11.
Yeah.
I have 4 more. Maybe there are 1 and 2.
Yeah. Or we can do I don't know, 5-minute break and then.
Okay, anyway, we start third one and do whatever we can. Because then other speakers will come. Okay, patient's medical knowledge, when it is beneficial and when is it an obstacle to return to health. Now, okay, when the patient comes to you, you have to assess him, and then this is the first considerations, and then we see, we go back to this particular issue of assessing the patient when it presents to you. What it provides is a valuable information. What kind of psychological type is this patient? Does he understand what we're talking about? Is he cooperative? Can I trust the patient in managing when I prescribe my treatment? Now, I found this paper, I found it interesting. There are there are 3 sources of learning for the patient that come to your attention. One group of patients is focused on self, and another group of patients is focused on the system, and I'm going to explain all these things. The third group of patients is knowledge is based on the community, what he gets from the community. Now, this is more specific. Under the source self, there are 2 types: embodied knowledge and monitoring knowledge. Embodied knowledge means that the patient speaks out of his physical feelings like pain, discomfort, insomnia, all these disturbances. And so basically, that's what it is capable to transmit to the doctor. Others, the monitoring knowledge, the first one is called sensory. Second one is like observation. Basically, you have a patient and he says, "Doctor, I noticed that in the morning I am like this, then I measure the pressure will be very high, when it goes down, or when I eat this I get disturbance," or basically monitoring the daily life and basically making observation about like a cause-effect relationship of different situations. Now the group focused on the system for learning. There are the medical knowledge, those who have medical knowledge, and those who have navigation knowledge. Now, basically, the medical knowledge, let's say the system comes from the use of healthcare interaction, healthcare and interaction of doctors. Basically, going to the hospital, learning and speaking with the doctors, documenting themselves, reading. This is the best way, the best knowledge that the patient can have, because it's more documented, and also the language is more precise and using proper terms. Whereas the navigation knowledge is more like a learning by using the healthcare facilities, knowing where to go, knowing the name of the doctor that can do this, and then so basically they don't really know medicine, but they know how to get around medicine. And then there is the group based on community knowledge, and there are two types: relational knowledge and cultural knowledge. The first one is like, for example, you have community groups that unite and discuss about problems, and they acquire knowledge from that, from those encounters. And then cultural knowledge is more like cultural religious codes. So in a certain group, like a Jehovah's Witnesses, they don't want to have blood, or if they are Muslim, they don't, etc., etc. There are different beliefs. So this is just for the doctor to understand what is the background of these people. Okay. Now, being for example, if a very educated person comes to the doctor, not necessarily is good in understanding medicine. Medicine is best understood by those who pursue the knowledge of the specific problems that they are encountering, and so they document themselves. They know what they're talking about. They describe in the proper terms. Anyway, this is just to understand the patient. Now, again, this couple of slides to say recognizing the patient knowledge, the first step towards partnership and value creation. So first of all, patients, as we saw, are not all equal. Health and social inequalities affect capacity to learn and manage knowledge. First. Now, for example, you have to aim at the transmitting knowledge to the patients. So you change the focus from who can or cannot acquire, and mobilize knowledge to what, when, and where knowledge can be acquired along one's journey. So if you start making a good explanation, big explanation to a patient, don't expect it to understand, take note, and remember everything. It's along the way, when proceeding with the treatment, you can build the knowledge of this patient step by step, by examining the different stages of the disease. So clarify the idea of patients. First of all, the idea of patient types and sources of knowledge, and this may help the physician to guide the track for the particular patient, to learn more about their condition, and therefore become more responsible and cooperative in the treatment. Okay. Yes, some patients have the influence of social ideas and religious beliefs. We saw the 6 types of knowledge, the cultural one. And what is important, the doctor should be motivated to develop the patient's knowledge and autonomy, and rebalance the power relationship that historically undervalues patients' perspective, experiences, and preferences. So you make the patient your partner in the treatment of their condition, not as just your animal lab that you do the whole you have to do, and you just decide what to do, and when, etc. You want to make them participate in the treatment. When is a when patient medical knowledge is beneficial? When you see that there is an increased engagement, adherence, and self-efficacy, so the patients following very well along the indication, then this leads to reduced number of hospitalization and emergency visits. When the communication, when the patient develop increased capacity of communication and shared decision making, so the patients engage more effectively with doctors, bringing relevant questions and participate in decision, which increases satisfaction about the quality of care. And when it's beneficial, when this knowledge empowers patients and improves quality of life, because the patients start to understand, they have access to validate information, which leads to empowerment of the patients and reduction of unnecessary visits, etc., etc. Now, when is the patient knowledge an obstacle? When there is risk of misinterpretation, anxiety, misinformation. Usually, it's a mixed responsibility here. Could be a poor information provided by the doctor, or poor information that the patient gives to the doctor. This can lead to incorrect self-diagnosis, anxiety, unnecessary treatment, mistrust in healthcare providers. There may be health literacy gaps and cognitive overload. Many patients, even those well educated, struggle in understanding complex health information, or may forget the drug purposes and doses. So, again, even well educated may not follow exactly what you say, maybe forget. So they cannot trust all the time. Fragmented or inaccurate use of information. It's probably more the responsibility of the doctor that does not provide a proper information and teaching of the patients. So education of the patient must go beyond mere information delivery. And then there are also socioeconomic and cultural influences. If there is a reduced education, language barriers, cultural differences, this leads to reduced communication. Okay. Pros and cons of patients having any medical knowledge. Pros are increased treatment adherence, increased informed decision making, better self-management, reduced anxiety, but also increased anxiety, the cons. Patient empowerment, early detection. The cons include information overload that they cannot handle, anxiety and fear. So the anxiety can come either as a pro as a cons. As you know, the patient tend to do self-diagnosis and treatment. For example, the ones that have sensory knowledge, like embodied knowledge, they go by what they feel, not what the doctor says sometimes. The doctor gives 40 milligram omeprazole, and the patient divides in two because 20 milligram maybe is better for him, depending on the type of patient. I know this for a personal experience. My wife, she was at omeprazole 20 milligram. They give you 40, then 20 milligram. Okay, what to do? Self-diagnosis and treatment, difficult understanding the jargon, difficult processing information, potential for mistrust. These are the cons. Information is beneficial when it is accurate, contextualized, and paired with the supportive communication. We will look at that also. It's problematic when the information is misunderstood, anxiety producing, or poorly interpreted. Basically, there is need for tailored education according to the type of patient, his ability to understand, to follow the indication, and so on. So it has to be contextualized. Strategies for good patient knowledge. The teach-back method. One doctor gives a prescription treatment and asks the patient to repeat what he said, how to do. So, like it was at school, you know, I teach you, you have to repeat. Clear, culturally sensitive communication using plain language, visual aids, translation support helps, and so on. High quality contextual information, evidence-based resources, empower patients thoughtfully. Again, it has to be related to also their particular problem. The doctor has to explain what this medication does for that particular problem, and maybe even provide indications to what could be the different reactions to that. Patient-provider partnership, having a collaborative relationship grounded in trust and mutual participation, that this optimizes the benefits of medical knowledge. So these are the strategies for good patient knowledge. Some practical and effective education tools, digital visual tools, videos, simulators, etc. Communication techniques, plain language, visual aids, narratives, teach-back, ask me, I don't know this one, open-ended question. Assessment tools, there are some forms to assess the understanding of the patient, and systemic and technology aids. This can forget about this. Anyway, there are instruments, tools to educate patients, and there are ways also to assess what they have learned. So the correct approach of doctor to patient is professionalism. This lady, Yolanda, right? Yolanda was saying exactly these things. You need to be professional in the approach of the patient, show respect and empathy, being kind, respect the values, the beliefs, having compassion, provide effective communication, which includes active listening, clear explanation, honest information, building a rapport with the patient, share decision making, so reach a conclusion together what is the best for the patient. Other considerations, boundaries, continuity, holistic approach, acknowledging own limits, understanding the type of patients. Okay, that reinforces the concept. Now this is the spiral means that how the wrong approach doctor to patient ends. See initial expectations of the patient, so the patient visit, and there are a number of steps that lead to less and less believing, trusting, starting non-adherence to the prescriptions, looking for alternatives. In the end, the patient doesn't trust the doctor anymore, asking more and more tests to do, and in the end, the result of the wrong approach is a decline of quality and outcomes, inequality and outcomes, so bad quality of medicine. There are problematic patients, those who have passive-aggressive psychology versus lack of trust, and they show non-compliance, aggression, manipulation, excessive demands, difficult communication, other funny behaviors. What is, in the patient's opinion, a bad doctor? It is also important. Lack of social skills and communication. There are some excellent doctors. They don't know how to communicate, they know how to empathize with the patient, how to, to treat them properly. So no empathy, poor communication, arrogance or condescension, inattentiveness and lack of eye contact. So it's writing, facing question without even having a visual contact. Make professional competence or incompetence, making mistakes, lack of knowledge, poor referrals, and follow-up lead to bad impression about the doctor. Other factors, and this is also very important, disregarding for patient time, focus on money, discrimination, and prejudice. So the doctor is clearly not interested in the good health of the patient, just interested in their own business and interest, etc. Now, this is, you could see a good relationship, doctor-patient, but negative. Considering the obvious lies on your information form and my tendency to misdiagnose, we should get along just fine. This is not the best way of interaction of the doctor to patient. And I think this is it. So, it is an important issue, how to interact with the patient. And again, respect, being empathic, listening, all this attention to the person, and clear dedication to solving his problems, and not to his own interests. And of course, not all patients are equal, and one has to identify what kind of person is in front. With some patients, it's very difficult to get along with, and you just hope that they go somewhere else, because they can create only problems. So this is the third topic. If there are any comments? Just tired. I think we need
I have a question about that strategy about talking to patient, that you ask the patient to prescribe what he or she understood about that.
the teach-back method.
Yes, because I heard about it earlier, but I think that a little sound like how to apply it without looking like the patient is not too intelligent.
Yeah.
No.
Yeah,
To not make feel
I
him
understand.
like a child.
I understand.
Okay.
You're right. Can be like that, but there are people, simple people. They may not even get offended for that,
No.
because people coming from areas that clearly they don't have a culture, they don't have a schooling. Just treat them with sympathy, that man, can you repeat exactly what I told you? Maybe especially the old individuals, because the memory goes. So it has to be done in a nice way, not let's say they do the test. If you by the way, there's a test at the end of this meeting, so it's going to be very select. Only 10% pass, usually. Just to make you worry a little bit. Just kidding. So this teach-back method, you have to do it in a proper way. But I've seen many times very simple people go to the doctor. They don't like to be treated like kids, basically. But it's true. You don't want to treat them as stupid.
Mm.
Yeah. Anyway, I think you can agree with what you said. You need to be empathic, interested, dedicated, listening, spend time. And this is in contrast with the demands of the hospitals, because you cannot finish. I speak also in my field, but pediatric cardiology visit. Usually I was not doing because cardiologists to do the echoes, but really to do echoes in complex heart conditions, you need time. The hospital asks you to do how many patients you seen this morning. You cannot do everything in 10 minutes, especially if you have some instrumental assessment like echocardiographic examination. You cannot do it in 15 minutes, finish everything. When I do a consent, I can stay even 1 hour, because usually what I do, I go with I prepare before what to say, because I make it schematically on 1 page. So the basic anomaly, the normal heart, the features, the anomaly, the additional problematics that this patient has, and figures of the treatment. And on the other column, the diagnosis, the plan of the operations, the use of cardiopulmonary bypass, and the risks. It can be, especially the complex ones, can be long list of things. And depending also on how the patients, if they know already, because maybe in the second stage, third stage, they know what we're talking about, or the first time and they are lost, they need to explain everything. So I had 5 stars all the meetings I had with patients, because I spent time with them. But cardiologists were forced to do many visits for productivity. And this is in contrast with what we said, because you need to dedicate time to the patient. So it's not easy. Not easy.
And how to not take the feelings of patients yourself, like go home and I don't know.
Repeat this, because I'm not sure I understood.
Work-life balance.
Yeah.
What?
Work-life balance. So
Like-
how to leave work inside work and not to take it to the home.
Yeah.
Impossible.
No, depending, where you see, situation is really getting worse in every field. It's even speaking mostly for not only Italy. It's my country, which basically there are few doctors. Those who have usually the ones that are in charge of the good hospitals, the heads of departments, they all organize outside private activity as well. And by the way, I've been in Africa, and there that is basically their salary is nothing. And these doctors, they all have a private activity, because there are patients that good for them, they can pay. But basically there is a deviation of doctors towards the private sector, and not everybody can afford. We will touch on this maybe in the next lecture, I think. And how to balance. Yeah, it is in the recommendation. You remember CTIC, the one you said, the integrity, check the integrity, that you are capable of, you were arrested, you can take responsibility, but not always possible. And when you do something like long operations, as I said, you cannot leave the patient there because you're tired, continue tomorrow, you cannot do that. So there are situations in which you can organize yourself in a way that you limit the sufferance, and you need to get some rest. However, I would want to say something else. yeah, the hospitals, they demand productivity. And you either do productivity that you get with bad feelings from the patients because they don't judge you well, because you don't dedicate enough time, attention, etc., etc. So it's a little bit, it's difficult to find, even for me, for example, I cannot do in 10 minutes what I usually take 1 hour to explain and gain the trust, sympathy of the patient. You need time. See what we just said in our dedication to the patient and respect is against those situations that are currently in place. So difficult to do the balance. Hopefully, in a place there are enough colleagues that you can distribute the work, but not always the case. And if you want to work, you have to take it. There is a way of saying either you o mangi questa minestra o salti dalla finestra. That means either you eat the soup or you jump out of the window. You cannot let it work, right? And take a little money home at the end of the month. Is it time for a break or I don't know, I'm just saying.
At 11, we have.
At 11, so we have done 2 and 3, we go to 4, and there are 2 left. Okay, and then you talk. The 4th is medical cooperation. I'll try to do quickly. Medical cooperation and its aspects. Now, we are saying is right now there are increased needs in healthcare and reduced resources. Needs is technological advances, the use of artificial intelligence, virtual and remote care, big data and analytics, patient reporting properly patient outcomes, resource and healthcare plans, electronic health records, increasing restrictive regulation, and need for strategic planning. Increasing needs. Reduced resources, need for reduction of costs. There is a workforce shortages. Those who remaining undergo burnout and also are poorly remunerated. Need to improve patient experience and access. What we were saying before, if you don't dedicate time and attention, the quality of your work is worse. Addressing health equity concerns, and that considering there is increased privatization and reduced efficiency of public healthcare facilities. The current hospital leaders, technocrats domain. Why do I say this? There's an old paper of cardiac surgery that I one of the geniuses in my field that he realized that with time, so when I started to work in the hospital in Rome, there was a group of leaders, doctors, basically they were doctors. And the hospital was like a happy island. They understood the needs, they were empathetic, they tried to collaborate, to help, to give all the resources necessary. With time, those were replaced by technocrats, the administrative people. And so you, as doctors, you become like the puppets under the dominion of this category of people that only look at that which is also needed, the affordability, resources, the profits and losses. Now, what is medical cooperation? It's a core feature of integrated healthcare across different levels, we see them, to promote more efficient use of health services and resources while improving health outcomes. Now, there are different levels of this collaboration. We can have interdisciplinary, institutional, national, international. Interdisciplinary, basically, I do my example, for example. Either I call or I am called by somebody that is actually I've been going for, and I'm going in 2 weeks to 2 colleagues to do some type of different type of operation, complex type. So an expert colleague, you ask expert advice of a colleague in your own discipline. Interdisciplinary means that you do a multi-specialistic meeting in which a complex patient with a lot of problems is discussed in a holistic way, and all the thoughts about the proper treatment for this patient, considering also the steps, the timing of each thing that needs to be done on this patient. And then you see different types of collaboration at institutional, national, international level between hospital, both governmental hospital and maybe all governmental and private, in order to have a better sharing of resources and also expertise. So key aspects of medical cooperation: interdisciplinary collaboration, any holistic care, coordination care with increased communication, maybe courses for educating your colleagues, information plus expertise sharing. As I said, like interdisciplinary, you ask somebody with more knowledge and experience in particular problem to help you in decision making, even doing performing the whatever needs to be performed. Resource optimization. This medical cooperation can lead to resource optimization, including staff, equipment, facilities. Again, shared decision making between different entities, including the patients. International cooperation to address global health challenges, shared knowledge and resources. Emergency preparedness for public health emergencies like pandemic, or there is or maybe there is a flood in the country and you send earthquake, etc. Research and innovation also can be promoted by medical cooperation. The benefits are eventually better outcomes, with more accurate diagnosis, effective treatments, better overall results, better efficiency with streamlining the processes, optimization of resources and reduction of costs, improved patient experience, and improved access to healthcare. Benefits, again, better staff morale, preparedness for emergency, again, knowledge and expertise sharing and innovation, aiming at the best practices and research, faster medical advancement, strengthened healthcare system. Challenges of medical cooperation. There can be issues with data security and privacy, regulatory differences, like different rules in different institutions or countries, depending what cooperation is talking about, funding and politics, communication barriers. Examples of interdisciplinary collaboration: decision making for procedure in complex patients, This is more multi-specialistic, like in the same hospital, you have a patient with a lot of problems, so decision making for procedure in complex cases, managing chronic conditions, stroke care team, post-surgical care, palliative care team, pain management team, mental health care. So they all may need multiple resources effort to cope with these problems. For example, we see later in patients with drug addiction, there can be a collaboration of different entities, clinical, social, psychological, etc. For interinstitutional collaboration, there are different types of alliances and joint networks, information exchange during emergencies, like COVID, data-driven collaboration, so the big database sharing information, inter-hospital referrals for complex cases, public-private partnership, collaboration between public hospital and private healthcare providers or technology companies. Future direction, digital health platforms, telemedicine across borders, and artificial intelligence and big data in cooperative healthcare. Now let's go same cooperation, but so famous humanitarian medical surgical missions. The scope of their work should be providing emergency medical care or specialized treatment or broader healthcare services to which population? The target population are those communities affected by conflict, natural disaster, or lacking access to healthcare. Most of Africa is like that. Poor access to healthcare, there are wars, there are a number of problems, natural disaster, etc. Usually, this mission use limited time, trips vary in length according to projects. They should focus on sustainability, training should aim at training local healthcare professionals and supporting local healthcare systems for long-term improvements, which is not many times the case. You just go there to, we see now in the next slide. Opportunities for, this I don't like, to be honest. Opportunities for volunteers, medical professionals, students to practice and contribute to global health. Yes, they contribute, but you cannot go there just to learn on African patients, for example, how to do surgery, like they were animal labs. Sorry for the comparison. You should go there that you are fully trained and that really help these poor people not to go there to teach your young people that you don't want to train in your facility. See, this terms volunteerism is ultimately about the fulfillment of the volunteers, not necessarily the needs of community or the needs of the communities they aim to serve. This is Peter Beagle who wrote this book. And so many missions end up with plenty of pictures showing triumphant surgeons with the little patients. I have one for myself, I'll show you. But the idea should be to go there to start a long-term program. But most of the time it doesn't happen. You go there to, because it's nice, because you travel, you see different places, you see, even if you are experienced with practice, you do see different situations. So it is nice to do, but it should be done with a different spirit. In fact, this is the framework for designing ethical humanitarian medical missions. First of all, one should assess the needs. Basically, base the work on real, verified local needs. Prioritize local skill building. continuity, ensure follow-up care is available, because see, go to these places, do a beautiful thing, and then you don't know what happens 1 week later or years later. The patients are just left without follow-up. And there are legal, ethical considerations following need to follow all laws and standards of the place where you go, respect cultural, local norms and values, evaluation, measure and report outcomes openly, boundaries, avoid performative or exploitative work. So there are a lot of aspects to be considered to do a proper job and not balloon tourism only. Now, I've been involved in several missions, both when I was working during my career, and this is recently in Kenya. And yes, the idea is to go there to build something. To be honest, with all the good intentions, what we find there is almost nothing. There is a surgeon there, I don't want to make open criticism, but this guy did not develop anything, and he works in a private clinic. He only gets a salary there because he's director of this center, but he cannot do children, for example, and some few adults with high mortality. So what he does, he works mostly in private clinic, doing simpler operations. So this is how can you build a future in a place where the leadership is like that, and there's no young people that want to join there because there is no hope for the future. It is also contextual to the place where you go. And in fact, next time I should go to a different place, but next year probably also Rwanda. So medical cooperation conclusions. Medical cooperation is essential to addressing today's complex health challenges. It unites institutions, countries, and professionals to improve care and save lives. From humanitarian missions to research partnerships, cooperation drives innovation and equity. Ongoing collaboration strengthens health system, especially in times of crisis. The more connected healthcare world means better outcomes for all. In fact, these are two statements. One is adopted from the World Health Organization principles. Health is a human right, and cooperation is the path to make it universal. Medical cooperation is more than sharing knowledge and resources. It is a shared moral commitment to the idea that no life is more valuable than another, no matter where it begins or ends. This is an anonymous statement. And this is the end. So this closes the fourth topic, which is medical cooperation. Comments? I mean, I think there are clear concepts. There's not much to contest. You know, the obvious things, and should be done with the best of intentions. But you know, there are many different perspectives of this, and nowadays, yeah, considering the first, remember the first slide, increased needs, reduced resources. That is the problem. And medical cooperation can really help with that. And this humanitarian thing is a different chapter. It should be done individualizing places where there are really motivated people, starting from leadership, and they want to build a program to serve their countries, and work with them, helping them to develop the knowledge, experience, resources, and so on. And of course, Africa is. I have actually done this year a lecture at the fundraising event in Houston, and I spoke about Africa, situation in Africa, and the needs for increased access to healthcare. And there are a lot of capillary problems, starting from the poor pay of these healthcare providers. That's why they cannot focus. And those who are able to study, they will focus on private sector and working on only on patients they can afford. So the problem is that not everybody will have equity in the availability of proper care. In Italy now, if you go private, you get a consultation or even a radiological test within a week. If you go by healthcare system, I wanted to do a colonoscopy, gastroscopy plus colonoscopy. So I called the telephone number of the governmental place for I don't know how to say. Anyway, you want some medical treatment or assessment, and you call this place where you know that you basically don't pay, you pay very little, you know, like a little ticket, not a full private fee. So they told me there is possibility of doing gastroscopy in 1 year at another city, and colonoscopy. I wanted to do both the same with some, I don't want to, with sedation. So we need anesthetist as well. So another city 2 weeks later, so after 1 year, what about if I have a cancer? You know? So in fact, I had to, I don't have a cancer, by the way, but yeah, I had to book something within a month or something, even less, don't remember, very, very quick with the anesthetist. So it's, by the way, colonoscopy is recommended for all men, but also women, for individuals after, not even at such old age, like 40, 45, I don't know. You may know more than me about this, but it should be done regularly, every 5 years, if you have no particular signs or elements of suspicion. You can do every 5 years as a routine. But you know, if that is the response, either you remember in time and you book 1 year before, but not what you want. You need to accept what they offer. That's okay. So what are we doing now? It is quarter to 11. I have 2 more presentations. I don't know, other people are coming. Tell me what you want me to do, and
We have a small issue.
Może to zrestartujemy, co?
To znaczy,
New healthcare system, I think. We can have a break, and then at 11:30 it will be a small lecture of podiatrics, and then we will be a mass at 12.
okay.
And after lunch, you can say another lecture, and then about 8, about 6, it will be the last. Yeah.
Muszę się przegrzać.
Bo informatyczną wyłączyłem i włączyłem. Zobaczymy, co się
So the next one is about drug addictions,
Okay.
and the last one is about artificial intelligence. I would say the both relatively easy and more informative than maybe artificial intelligence, you know more than me, but I didn't tell you if you had any question about this one, cooperation questions.
I have a question from practice because I found it sometimes very hard in hospitals to collaborate between wards and doctors from different specialties because some don't want to collaborate.
They don't want.
Sometimes we call emergency that patient is dying and doctor says we are not funeral. It's very hard sometimes.
It's not acceptable.